my name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York. And I'm also professor and chair at the Department of Child and Adolescent Psychiatry, Charité University in Berlin, Germany. Olanzapine is a well-known medication that has shown good efficacy and also acceptability by patients. However, one of the problems that it can cause is weight gain and metabolic abnormalities. Olanzapine-Samidorphan was the attempt to keep the good efficacy of olanzapine, but reduce the weight gain that is associated with olanzapine treatment. Samidorphan is a mu-opioid receptor-preferring opioid antagonist, and it regulates appetite and also satiety. By combining these two medications in a single pill, patients have the assured efficacy of olanzapine, the benefits of that, with no additional side effects that we know of in terms of olanzapine's legacy data, but there is a reduction in appetite and weight increase. And it's not a weight loss drug, but due to this brain modification of satiety signaling, we believe that that then leads to the attenuation of weight gain after about a lag time of about 4 weeks. Obviously, we don't know exactly how our psychiatric diseases are in the brain conceptualized, nor do we know how exactly these medications work. But olanzapine is a dopamine 5-HT2A serotonin antagonist, and that is retained in this combination treatment of olanzapine-samidorphan. How much the opioid modulation also contributes to other symptom reductions that have to do with the illness is currently unclear. Currently, we measure efficacy in studies with the PANSS, the Positive and Negative Syndrome Scale. And that is composed of 7 items for positive symptoms: delusions, hallucinations, thought disorder, disorganized behavior. Negative symptoms, those are the things that are missing and people should have: amotivation, asociality, affective flattening, alogia, and also anhedonia, not enjoying things. And then there are these general psychopathology items, 16 of them, that have sleep, anxiety, agitation, and other things. Now, we do know that our postsynaptic dopamine blockers and antipsychotics work for positive symptoms. That's why they're approved for schizophrenia. But it's hard to actually treat the negative symptoms that, when positive symptoms are covered, both together with cognitive symptoms, have to do a lot with functional impairment. So having treatments that treat both positive but also have a beneficial effect on negative symptoms is really important. Now, in acute studies, what has been a criticism is that when positive symptoms decrease, they also improve negative symptoms secondarily. That's called pseudo-specificity. And in that sense, we can look at patients that have both predominant or prominent positive and negative symptoms. And we showed that in that subgroup that have an enrichment for positive and negative symptoms, we have about a 9-point decrease in negative symptoms. But then we looked also in a post-hoc analysis at a subgroup of patients that had predominant negative symptoms, meaning they had relatively few positive symptoms, but a lot of negative symptoms. And here, very close, about 8 points, was also observed that there's a reduction in negative symptoms with olanzapine-samidorphan in the patients that had predominant negative symptoms. Now, this has huge implications because as you improve negative symptoms, we would assume, and have also shown data in other studies, that there's more engagement with social life, with maybe work and school, and having a fuller ability to reach not just symptom reduction, but also recovery, functional recovery. And that's the ultimate goal when we treat people with schizophrenia. So when we study a medication, we start with randomized controlled trials to get this over the finish line for the Food and Drug Administration. So there was an acute study, 4 weeks, to show that adding samidorphan, an opioid antagonist, to olanzapine didn't detract from the efficacy of olanzapine. Check, that was shown. Then there was another randomized controlled trial looking at attenuation of weight gain overall and also in the people who gain at least 10%. That was a 6-month study. And again, check, that happened and was good. In a sub-analysis, we even showed that there was a reduction of a new incidence of metabolic syndrome, of hypertension. But the question then is, how does that translate from randomized controlled data, placebo-controlled, to the real world? And that's where the new data come from, looking at Komodo database, where a lot of patients that you and I treat, clinicians in the real world treat, what happens to these patients? And there were 2 types of analyses. The first one was looking at patients 6 months after they start Olanzapine-Samidorphan, and looking back 6 months, how did they do beforehand? So that's the switch study, or a new initiation of Olanzapine-Samidorphan. It's the same patient. The patient is their own control. So we keep a lot of the time invariant variables, the disease stage, the severity, the social environment, very stable. And what was shown was when people started Olanzapine-Samidorphan and were followed for 6 months, they had significant reduction in ER visits, hospitalizations, and also were more adherent. So that's pretty impressive, because that stability of treatment acceptance and maintenance is something that brings out better outcomes in the long run and saves also healthcare utilization. Another set of analyses then did a cohort study. The first one is a mirror image study. You compare the patient before and after a treatment change. The other one was a cohort study looking at patients who start Olanzapine-Samidorphan for 6 months and compare them against other medications that are started, and then there's matching on certain characteristics, because this is not a randomized trial, to make sure these patients are very evenly distributed in terms of the characteristics we have available. And what was shown was that Olanzapine-Samidorphan again had better adherence and also treatment continuation than these other antipsychotics. And this included even olanzapine per se, which is, I think, most surprising but also encouraging, that when olanzapine, the efficacy component is the same in the real-world patients, but you add samidorphan, reducing cardiometabolic burden, it seems that patients value this. Patients stay in treatment longer. They had, both in schizophrenia but also in bipolar disorder patients, significantly longer duration on the medication, which we know predicts better outcomes.